All right, I'm back for Chapter 6, starting on slide 31. I'll try to get through these kind of quick. We're talking about insurance and insurance types, public health insurance. Slide 31, Chapter 6. In 2011, almost a third of Americans had public health insurance. And your question may be, what is public health insurance? But it's government programs. So Medicare, Medicaid, CHIP, which is for children, military health services, active military, and then Veterans Affairs, so veterans, VA folks. Medicare is Title 18 under the Social Security Act. It's for older adults, so anyone 65 years or older, or anybody who's disabled and on Social Security, which you can be disabled at a younger age. And if you get disability, then you also get your Medicare benefit. I believe the way that works, though, is that you have to, for any Medicare, you have to work a certain number of hours over the course of your lifetime in order to be eligible for it. Medicare is a federal program, so all the money travels through the federal government. Medicaid, which we'll get to in a minute, is a state operated and managed program that has up to 50% match of government funds. But back to Medicare. It's for, again, older adults, so 65 years or older, folks on Social Security and disability, or anybody has end-stage renal disease. And about 83, well, in the 80% is how many, 83% of the people on Medicare are the older adults. The other 17% are the folks that are disabled and have end-stage renal disease. And it's a 4-part program. So there's Medicare Part A, Part B, Part C, and Part D. Part A is inpatient, basically. And it's financed by payroll taxes. So if you are gainfully employed and you get a paycheck stub, you'll see that every paycheck there's a line that says Medicare. That's where that money goes. And then there's also Social Security. There are no premiums because you basically worked and you paid your premiums out of that paycheck stub, and you've had to earn 40 credits. That's what they call it. 40 credits over the course of a lifetime. You can buy into Medicare Part A, so you can pay the difference of that cost per credit if you haven't worked enough over the course of your lifetime in order to access the benefit. But in the book, Exhibit 6.3 tells you what the benefits are, but here's a summary. You get 90 days of inpatient hospital care per benefit period. You get lifetime care of 190 days in a psychiatric facility, so an inpatient psych hospital. You can get home health through a Medicare certified home health agency. You can get up to 100 days in a Medicare certified skilled nursing facility or nursing home. And you can get hospice. Now what's interesting is that like nursing home care, you got to remember Medicare was set up a long time ago. It was the original Medigap, if you want to call it a Medigap insurance program. Because people generally had a pension that covered health benefits when they retired from whatever their employer. But the way that it works now is that you can be in a skilled nursing facility for 100 days, and then you have to not use the benefit for a certain period of time. I believe it's 30 days. But then, if you're still qualified for a Medicare covered stay, they pick you up and you go another 100 days. And you can do that. You daisy chain it. So if you think of an older adult who really needs to live in a nursing home, they may be able to use their Medicare benefit all year round, but you can only stay there 100 days at a crack, if that makes sense. So Medicare Part B, or SMI, it's a voluntary program, but that's for outpatient services. And it's voluntary, so you're entitled to it, but it's voluntary. So at 65, you can opt for it, which then you pay a premium, and then there's a deductible, and it's an 80-20 type of deal, and it covers outpatient services. And Exhibit 6.4 has a list of what it's covered. Medicare Part C is a Medicare Advantage plan, and it was created in 1997, and they call it Medicare Choice is what they used to call it, and a lot of places still call it that. But it's voluntary enrollment in managed care. So insurance companies can put together Medicare Advantage plans and make them available. The insurance company has to adhere to the rules of Medicare for the most part, but what they can do is they can be flexible on the benefits, and some people like that. So for instance, on our Medicare Advantage plan, maybe if you're diabetic, you can get diabetic shoes, but under another one, under straight Medicare, you couldn't, something like that. But the advantage to Medicare is that they've outsourced it, and at least to like United Healthcare or something like that. And then in general, United is then a bit at risk to manage those dollars, which and Medicare's not. The federal government's not. So there's a benefit each way. Let's see, doesn't add any specific benefits, but may provide some extras. And there's an additional premium, but there's no need for Medigap. So you might have to pay an additional premium if you get on it. In 2014, under the Affordable Care Act, the Affordable Care Act wanted to reduce payments to Medicare Advantage plans. What they were trying to do is control cost and spending, and the goal was to achieve some level of parity between Part C plans compared to regular in the original Medicare program. The hope was the Affordable Care Act could bring those costs back into line, because as you're probably aware, there's a big concern of Medicare running out of money, and well, the government's trying creative ways to do that. The government consistently says that Medicare Advantage plans over time have been overpaid. And the reason why they say that is that Medicare Advantage plans, who are usually sponsored by insurance companies, end up running a margin. So they make a margin, they make a profit basically off the Medicare business. And the government sees that and says, well, hold it, then we must be giving you too much money, and then they try to ratchet it down. Now the insurance companies say, well, no, we're for-profit, most of them are for-profit businesses, and that they're just being good stewards of the program. And then they contend back that, well, government, why are you penalizing us for being good business people? And it goes on around and around and around and around. So that's Part C. Medicare Part D is the prescription plan. It was created under Medicare in 2003 and implemented in 2006. You can, if you're an enrollee, you can get a standalone plan just for prescriptions, or you can get into a Part C program, so part of managed care, and it can be prescriptions and other stuff, depending upon what the managed care payer wants to offer. It's voluntary, premiums are subsidized, and if you look at Exhibit 6.5, you'll see what's covered. So a big, we'll talk about Medicare out-of-pocket costs. I'm on slide number 39. There's no limits on out-of-pocket expenses in the original Medicare program. So generally, a typical beneficiary, a typical insured person would spend about 20% of their annual income, and in some cases that's Social Security, maybe a pension if they have it, but 20% of that would go toward medical costs. Nearly half, but now near half of the Medicare Advantage plans have cost-sharing limits, meaning a beneficiary's spending is capped, that maybe it's capped at 8% or 9% or 10% of their income, or it's a flat dollar amount, which is one of the things that Medicare Advantage plans will use that as a selling point to get more people to enroll into their plans. So they'll say, look,
we cap the out-of-pocket costs. Medicare doesn't. So you're on the hook for 20% of whatever without any limit. So that's one of the things that they sell it on. Which gets back to the previous presentation, which is part of the same chapter, but we were talking about insurance as a financing mechanism. Medicare consumes over 1/5 of the national health expenditures. So think about that. That's over 20% of all health expenditures in the country go through Medicare alone. That's a lot. There are trust funds, Medicare Part A and Part B trust funds, which is, so what's a trust fund? A trust fund is when your paycheck they take the money out of your paycheck. That premium that comes out doesn't go into an account with your name on it. It goes into a trust fund or a bucket. Think of one big bucket. And so there's a Medicare Part A bucket and a Medicare Part B bucket that all those premiums go into. If you remember from the earlier one, the goal for any insurance company is to have more money going in the bucket, or money going into the bucket faster than people are taking money out. And one of the problems that through 2012, both buckets, Medicare Part A and Part B, were seeing deficits, meaning they were spending more than they were taking in. Now, some say that there's a pretty big war chest out there, but the problem is if you take out more than you're putting in over time, you're going to run out. And different ways to manage that is, elevate the eligibility age, which they've done, limit benefits, or reduce, the number and types of things that are covered, stuff like that. The three main issues with Medicare financing and spending is that just in general, the cost of living and care continues to rise. It keeps going up and up and up and up. People don't like to be taxed. I don't know about you, but I'm not a big fan of seeing my taxes go up. Now that said, if my taxes went up, but the amount I spent on premiums for health insurance went down, I'd be okay with it because I'm spending money on it anyway. But I guess that's a whole other class we could talk about. But rising costs of delivering care, which is a problem for Medicare. So even more and more people are becoming eligible to use Medicare. So the number of people pulling money out of the bucket or eligible to pull money out of the bucket continues to rise. But at the same time, they're pulling out money at a faster rate because things are more expensive. So it's like a double hit. I'm pulling money out of the bucket. What else do we know about aging populations? Well, we know that as people get older, they consume more health care. In previous presentations, I drew that bell-shaped curve. And I think of it as a roller coaster. And we're about at the top of the roller coaster where there's more people over the age of 65 than anybody else in our country. And we know that things start to wear out and things start to break on our bodies as we get older. So if they're eligible after 65, if they're living after 65, we know they're eligible for Medicare. If things go wrong, there's a 99% chance that they're going to use Medicare to cover their health expenses. So rising costs of delivering care, increasing costs. More people getting older, which increases cost. And there's also a shrinking workforce that are putting taxes into the buckets. All this relies on tax dollars, and we've been having a shrinking workforce in our country for a number of years. Right now, in 2018, we happen to be at the lowest unemployment we've seen in decades, but which is really, really good. It's good that people have jobs. That's wonderful. But we have less higher paying jobs, less manufacturing jobs in our country today than we did when Medicare first came on. So even today there might be more people working paying taxes, but they're paying taxes off of smaller or lower salaries. So not as much money is going into the bucket. So that's a concern as well. But let's talk about Medicaid. I'm on slide 41. Medicaid or Title 19 of the Social Security Act finances health care for low-income folks, and each state defines what low-income or indigent is the correct word what indigent means. And it's jointly financed by federal and state funds. So the federal government uses matching funds. Think of it as a carrot out in front of the state to get the state to do kind of what the federal government would like as far as healthcare goes. And as an example, perhaps if you, well, they did this a number of years ago where the sale of cigarettes. Well, let's even just say the drinking age. Wisconsin was known for a long time that the drinking age in Wisconsin was 18, and our neighbor to the south, Illinois, was 21. Well, the federal government used funds, matching funds, off of Medicaid to convince the state of Wisconsin to raise the drinking age to 21, saying, hey, you're not going to get your full match unless you raise your drinking age to 21. And the federal government can match up to 50% of the dollars going into Medicaid. So, yes, it's a state program. It's managed by the state and dictated by the state, but the feds have a big influence on it based on the match. The Supreme Court struck down a mandate under the Affordable Care Act that would have given states a choice either to expand or not expand their Medicaid program without a penalty from the federal government. So the Affordable Care Act was put into place to slow down spending and increase the number of people with health benefits. The thought was that if you get more people paying some sort of premium, putting money in the bucket, that would help it out. And the federal government tried to make it a law that states had to expand their Medicaid programs. And if they didn't, they would get penalized. But the states fought on that and ultimately won. There wasn't a mandate that they had to expand Medicaid. And in fact, Wisconsin was unique because there was a big political issue. There was a gubernatorial election at the time. But Wisconsin was one of the places that did not expand the Affordable Care Act under Medicaid. So, because there's so much going on with it and it's not standardized, there's a whole lot of uncertainty in the program, especially at the state level. All right, I'm at slide 43 now. Medicaid under the Affordable Care Act, this was unique, is that states can no longer use assets to determine eligibility. So basically, states can only look at income, not assets. So you could be sitting on $1 million house, and that would not count against you for your eligibility for Medicaid. And the logic there was, well, sure, the house might be worth $1 million, but then I'd have to sell the house, so then I'd be homeless. And also, can't guarantee that you're going to sell your house. So that was a big point of contention. And then Medicaid under the Affordable Care Act, the state can include preventive services if they wanted to for existing beneficiaries. Under other Affordable Care Act programs, and even under the mandates for commercial insurance, there was a mandate to include lots of preventative services, but that didn't fly under Medicaid. So under old Medicaid, before the Affordable Care Act, or for states that chose not to adopt the Affordable Care Act, there's automatic eligibility, and it's based on TANF, T-A-N-F recipients, which is it's a government program. You can look it up to figure out what it is. Social Security, if you're on Social Security, you're automatically eligible. Children and pregnant women, if your income is at or below 133 degrees of the federal poverty level. And medically needy as determined by the state. So that's how you got eligible for Medicaid. Now, there's something called dual eligibility, and that's where you're eligible for Medicare and Medicaid. So you're 65 years old or older, and you're an SSI recipient. I suppose if you're 65 and pregnant, well, I'm sure that's happened, but maybe not a lot. Or 133% of the federal poverty level, or defined as medically needy, you could be dually eligible. You could be eligible for Medicare and Medicaid. There is full duals and partial duals. So you, especially under the managed care methodologies, and then under the Affordable Care Act for dually eligible people. The goal was actually to use mechanisms to get people to be fully dually eligible under Medicare and Medicaid. And it's very, very common under the Affordable Care Act. Medicaid and dually eligible populations under Medicaid becomes capitated. So there's just a flat amount of money that the federal government will give to the state to meet all the healthcare needs of individuals at a given time, or like for a period, for a year, or something like that. Let's see, CHIP. Now I'll just quickly go through the other ones. There's CHIP, which is Children's Health Insurance Program. It's Title 21. So we've been Title 18, Title 19, Title 21 is children. It's a federal block grant to state. So what that means is the state applies for a block grant under Medicaid for these children, and then the feds just give a big chunk of money and one big chunk block to the state to cover the services eligible under the program for the given year. There's no income threshold, but states generally cover children up to the age of 19, and in families with incomes up to 200% of the federal poverty level. But you can't get in CHIP unless you've tried to get into regular Medicaid first, and for whatever reason didn't get in. So you can't go straight into CHIP. You got to go and try to get into Medicaid first. There's healthcare for the military, which we talked. I told you about in the beginning. Money goes to the federal government for active duty and retirees, their dependents, and their survivors. Each branch in the military operates its own medical facilities. I don't know if you knew that or not. And TRICARE is the insurance arm to cover all of those. The Veterans Health Administration, or VHA, or VA, is the largest system in the United States, believe it or not.
I wonder if that's true now, though. Because Ascension Health, which is a large Catholic hospital system, has just been going on a rampage, gobbling up other systems. But at least at the time of the writing of the book and the information, the VA was the largest health system in the country. Let's see, people get care based on priority and need. In general, it's considered to be pretty well managed. It ran into some rockiness over the last couple of years about mismanagement and things like that. But really, over the long haul, the VA historically has proven to be a pretty well-run organization, even though it's seen some hard times lately. Services are organized through 23 geographically distributed VAs, so our VA network. So there's 23 different geographical areas that are managed as a geographical division, or what's the word I'm looking for? Region, as a geographic region. So you'll have a hub of like a tertiary VA hospital, and that can be an anchor for a geographical area, and there's 23 of those. There's also the Indian Health Services, which is also totally a federal program. It's comprehensive care to Native Americans living on reservations and in rural areas. That was what part of the deal that was struck to provide Native Americans with health care. It operates its own hospitals and clinics and all that kind of stuff. It's completely separate from anything else, but it's primarily for people living on reservations. Let's talk about payment. I'm now on slide, looks like 51. You'll hear the term third-party payer. And what that means is that, like for instance, an insurance company like Blue Cross Blue Shield or United will take on a couple of key functions in the provision of healthcare services. They figure out what reimbursement will be to the providers,
and then they actually make the payment to the providers. And in some cases, the federal government will contract with like the Blue Cross Blue Shield or an Anthem or United to be the third party administrator for them. So money will go from the federal government, and then Blue Cross will manage that benefit for them. So let's talk about some terms. I'm on slide 52. There's a big difference between the actual cost of a care being provided and the price and what's actually charged. The charge is the rate set by the provider. So I could charge you $1,000 for a surgery, but if I've agreed to take Medicare as an payment in full, which is required, it's called assignment. Medicare may only reimburse $400 for that service. So regardless of how much I charge, Medicare is only giving me $400. So that's what the third-party payer agrees to pay. So in this case, like Medicare, maybe through Aetna or whatever, that $400 is the rate. So my charge is $1,000, but the rate is $400. Then I have to write off that $600 somehow in the financials to reconcile it. Each third-party payer has, generally, if it's prospective payment, so price is agreed upon before. So, broken arm, $400, stub toe, $35. Regardless of where it is and how it is, if that's the rate, that will be published somewhere in a fee schedule, is what it's called. And it's an index of charges listing the fees for each type of service. So it could be for surgery around my broken toe or bandages around my broken toe, things like that. Reimbursement is the mechanism or the name of what happens when someone who, like I have insurance, so I go to the doctor and the rate's $100 but the charge to me is $200. The rate is $100. They write that off, but the provider will then bill my insurance company and get reimbursed for the service. So you provide the service and then you get reimbursed for it. And there's several different kinds of reimbursement. There's fee for service, which that would be if I'm standing across the counter and I need stitches and I don't have insurance, or maybe I don't want to use my insurance for some reason. Hopefully I'll ask, hey, how much does it cost to get stitches? It's $35. Okay. I'll pay you $35. That's the fee for the service of getting stitches. Pretty easy. It's like going to the store, getting gas, something like that. That's fee for service. There's also bundled payments or package pricing. So things like around hip replacements and knee replacements. Medicare usually is the one who goes in and does the really creative things to create these options. But there's some they'll bundle the service, saying everything related to a knee replacement will be reimbursed at this amount, and that money goes to usually a provider, and the provider is then responsible for taking that lump sum and dividing it up between everybody that was involved. So the federal government only has to write one check or send one payment to the provider for the bundle, but then the provider will perhaps pay the doctor, pay room and board if it's an inpatient stay, or even if it's just for the afternoon. We'll pay for the x-rays and the medications and everything related to it. In the past, Medicare would basically be billed for all of those separately and would have to provide reimbursement to each of those separate entities within sometimes even in the same organization. So the physician group would send their bill, and the hospital will send its bill. And let's say there's a separate surgery center designation inside the hospital, then the surgery center would submit their bill. So Medicare would be, or the payer would, get a minimum of 3 bills for, my hip replacement. Under bundled services, they're like, I'm just going to drop a check to one of you, and you guys figure out how to split it. So that's how that works.
Managed care approaches. I can remember every healthcare plan these days is pretty much managed care. But managed care approaches around that would be where you they reduce reimbursement for things, or they restrict the providers, or yeah, I guess that's about all I can think of. But using managed care tactics, you can use managed care tactics or strategies to also manage the reimbursement along the way. Prospective payment was started with diagnostic related groups. I think I shared that with you before, but before the late 80s, early 90s, as it took hold across the whole country, everything was pretty much negotiated fee for service. So St. Luke's Hospital would negotiate with Medicare for the reimbursement rate on let's say a heart surgery, and then St. Mary's Hospital would negotiate for a rate on hearts, and those prices might be different. And so I'll imagine that around every single hospital, every single entity that provides that kind of service, Medicare was spending a lot of time negotiating contracts. Well, they came up with the idea, and it took quite a number of years to actually get it to work. Before they implemented it, I think 11 or 12 years. But now, the way it works today is that there is a Medicare fee schedule that gives the reimbursement rate for different procedure codes that have to relate to certain diagnostic codes, and there's a common baseline for everybody across the country. Now there might be a weighting scale that would help someone in New York perhaps get reimbursed a little more than someone in Wisconsin, but it's meant to be apples to apples across the board. So New York would get paid a little more because cost of living and cost of service cost more. Try buying an apple in a store in New York or an apple in a store in Milwaukee, Wisconsin. Most likely the apple will be more expensive in New York. Well, same thing, heart surgery is a little more expensive in New York. And that's prospective reimbursement because we know beforehand what we're going to get reimbursed. So prospective. Fee for service, the charges are set by the provider. That's like the $35 stitches. If I'm paying cash out of my own pocket, the provider doesn't necessarily have to adhere to the fee schedule that an insurance company or the federal government mandates, because it's just my cash. So the provider can set the charge. Now what's interesting is people might think, well, heck, I can control it, I'll charge more. Well, what actually happens is that if you go somewhere and you let them know and say, hey, I don't have any insurance and I'd really like to pay cash, odds are they'll actually charge you less than what the charges that they would have set up as their prices. They would, because it'll probably be somewhere between what their charge is and what Medicare would pay them. It'd probably be between that. So you probably get a better, in some cases you can get a better deal if you give them cash up front, because $1 today is worth more than something that you have to bill for and get $1, let's say 30, 60, 90 days from now. Plus it doesn't take any additional staff time. If someone's giving you cash right across the counter, you don't have to do any collections or anything like that. It's already there. So that's getting cash across the counter is always a good thing. But for fee for service, each service is billed separately. Think of it as a menu. Insurers adopted usual and customary and reasonable charges around fee for service, much like prospective payment. The federal government set through DRGs and Medicare prospectively what these certain things are, while other insurance companies then followed suit, and they call that usual and customary charges. One of the biggest drawbacks, though, is that fee for service, it's provider-induced demand. So the provider can generate a demand for more services by lowering their prices. Think back to the conversation we had in the immediately previous video for Chapter 6. It's like, if you lower the cost, more people are going to use it. So you can induce demand for that, which then increases healthcare expenditures overall.
All right, more about I think I already talked about bundled payments. I'm now on slide 55. But a bundled payment, think of it as a basket. You put a bunch of related services in a basket, and then you get paid a set amount for every single thing that's in that basket. It reduces provider-induced demand because because everything's lumped together. Part of the goal of it is to remove the incentive to nickel and dime and upcharge patients and insurance companies and things like that in the provider by the provider, because it's all bundled, it's all in there, that's all you're going to get, and the incentive is to actually use, at least to the provider, would be to use less than what's in there, because they want to keep, the more they provide, the more they're probably going to have to pay for it. It's going to cost them, so they provide a little less or be a little more efficient, then they can keep whatever the difference is, and that's the incentive there. There is evidence, because they've studied this over the last about 10 years, that prospectively set bundled fees, so like that knee replacement that I was telling you about, that if the whole basket for the knee is set, that over time healthcare expenditures related to that service in that bundle will go down. So that's correlational. So just know that. So what is an RBRVS, a resource-based relative value scale? That is a quiz question, by the way. Our RBRVS is used to reimburse physicians for their services. There's a CPT code, and I'm drawing a blank on what CPT stands for, but it's a relative value unit is assigned to a physician procedure code. It's procedure terminology, but I don't remember what the C stands for. But think of it as prospective payment for physicians' procedures. And that's where I was telling you about, for physicians, a physician in New York will get paid a little bit more because it's weighted higher based on that resource-based relative value unit, because apples cost more in New York compared to Wisconsin. And that's where the RBRVS comes in. It's the process that puts the weight or the differential on the procedure code to get it to be apples to apples reimbursement across the country. There's a lot in there. There's a lot in the chapter about that, so I suggest you read it. But those relative values are adjusted based on really some key things. It's geography and the cost of the resources within that geography, like cost of living, the cost to recruit and retain staff, things like that. And each year Medicare establishes a different conversion factor. So Medicare adjusts the weight every single year on this stuff. Managed care approaches. So remember managed care, which really often gets criticized because it's more like managed cost, is that some ways what they do is they develop preferred provider networks where they negotiate discounted fees for services or bundled payments or things like that with a set of docs, with the goal that to channel as many people through those physicians so that they know they're getting the absolute best deal and still getting great service. So that's what a preferred provider is, and they work off of discounted fee for service basically, or negotiated packages. Capitation is a per member per month fee to cover all the needed services. So this can think French Revolution and the guillotine, and decapitate your head. Capitation per head. It's a dollar amount per person, per head, per month to cover all of their services for a given year. It minimizes provider-induced demand and promotes, I use the word prudence in the slide, but capitation is you're only going to get $100 and you have to keep them healthy, but they don't want physicians or providers to do too much for people that's unnecessary. And the incentive is that if it costs you less than $100, you get to keep whatever you didn't spend. If it costs more than $100, it's on you, and that's the mechanism there. There's something called cost plus reimbursement. In general, that's for hospitals or institutions. Could be a psych hospital, inpatient hospital, or another institution. And it reimburses on a per diem rate or patient day rate, or PPD. We hear about PPDs all the time, inpatient, which is per diem rate on patient day rate. It's based on the total operating cost and a portion of capital costs to provide service on a daily rate. So think of it as room and board, staff, lights, all that kind of stuff, plus a teeny weeny bit of capital. And capital is used for replacing big things, or maintaining big things, or rebuilding big things. So it's all just the costs of doing business, taking care of that person, plus a little bit more for replacement and keeping things up to date in the future. It's also called retrospective reimbursement, because remember, prospective is this is all we're going to pay you going forward, flat fee. Cost plus reimbursement looks at, basically you get paid after the fact, and it looks back at what your costs were to provide that whole thing, and then it sets the rate looking backwards. A lot of organizations like cost plus because they feel like it's a better deal. It's not very popular anymore, though. It's almost everything has gone to prospective payment. The places that still go cost plus are really the hospitals or healthcare provider organizations way in rural areas, because it's still really hard to secure physicians and run hospitals and clinics and stuff like that in extremely rural areas, and or in very, very impoverished areas, oftentimes in the inner city of some cities. Prospective payment, I know I've talked about this. There's that's determining what you'll be paid in advance of actually providing the service. It helped Medicare to predict future healthcare spending, because then they look at, well, how many knees? Well, if knees are capped at a certain amount, and they look and say, well, based on population and demographic trends, we expect to do 20% more knees next year. We know that cost will, at a minimum, go up 20%. So it's helped that way. In general, organizations under prospective payment, organizations can only make a profit if they run really, really efficiently. So it's a lot more pressure on the provider organization, the hospitals and things like that. There's value-based reimbursement, which came back around with the Affordable Care Act, or called pay for performance. The goal is to reduce reimbursement while improving quality and efficiency. So think of it as a racking and stacking, and they do it where, based on quality outcomes and measurements, a lot of data analysis, they'll shuffle the deck, and the people who are deemed to be better providers, more efficient, more effective, get paid more than those that don't. And it's constantly, on an annual or a 6-month basis, being evaluated. So Medicare likes it because they feel like they're rewarding really good behavior, and it still helps reduce total expenditures. Providers find it hard because if, let's say, an organization gets paid the incentive for, for a year or two even, but then all of a sudden another organization, maybe a big hospital system or something like that, does something really, really unique that shoots them above in performance. The first organization may see their reimbursement drop, and they haven't done anything wrong. They used to be a top provider, but someone else got smarter, got better, and all of a sudden, aced them out. So that can get frustrating for providers. Let's see. So, and that's where the minimum data set comes in. That if organizations are taking Medicare, this is my dog, this is Rosie. She's a puppy. We actually have 2 dogs, but this is Rosie. She's very needy, so that's why I'm petting her. There, you have to do a minimum data set, or MDS, you're required to report that, and that's how they rack and stack your organization. So specifically about prospective payment, there's multiple ways to get paid prospectively. There's the DRG, Diagnostic Related Group. There's also a separate set of diagnostic related groups to psychiatric care, so that's psychiatric DRGs. There's also the Outpatient Prospective Payment System, or OPPS, and then there's also some case mix methods where you look at resource utilization groups, organizations that groups of people, providers that use certain resources. You can measure what they're doing and determine a prospective payment on them. Case mix, so how sick your folks are. Case mix is really popular among hospitals because they want to show that they take care of the sickest and most frail folks, so they can then negotiate a higher rate. In Milwaukee, Aurora does that really, really well. So does Frederick, and in general they get a little bit more than, let's say, St. Mary's Hospital does, based on that. And then home health resource groups. There's a big push to move services out into the home, and because it's a lot less expensive. At least the thought is it's a lot less expensive. So DRGs, I'm on slide 63, it looks like. Prospective payment for acute care hospitals are DRGs. Each DRG group, you have a principal diagnosis and then supporting codes around it. It's a fixed fee per case, so per broken arm or per heart attack or per whatever. It's not necessarily per person. It's per case, and or spell of care. The hospital has to provide whatever service the patient needs in that has that diagnosis, and adjustments can be made based on location. There, belly scratch, good girl. Based on location, whether they're getting a lot of low-income folks, stuff like that. Let's see. DRGs and severity grouping. So DRGs came out in the late 80s, or in the 90s, totally came to proliferation. But then patient severity was incorporated in 2007 to better reflect the resource use. So, broken arm or a head injury sustained in like a bad car accident could be determined to be more severe than a head injury of me falling down the steps. So it's probably a bad example, but there's an example that the severity of the situation could up reimbursement a little bit. 335 base DRGs are split into 751 with complications. That was in 2011. So originally there were 335, but then with the severity adjusters, it popped that up to 751. They're weighted and reviewed annually, and 65% of bad debts are added to reimbursement. There's an assumption out there that people aren't going to pay their bills, so that's a factor that's included in there. Let's see, the ACA and hospital reimbursement. I'm now on 65. The ACA imposes reimbursement penalties for excessive readmissions. That's not even just the ACA these days. Readmission penalty. Medicare is now penalizing organizations and people, doctors and hospitals, for readmission rates, and it's a big deal. So Mrs. Smith comes to the hospital, paid under Medicare. If she is discharged but then comes back within 30 days due to a complication or something to the original diagnosis, the reason why she was there, that's considered a readmission, and Medicare will can penalize the hospital for doing that, meaning take some of the money back, or not pay them for the services provided. So readmission is huge. Now I'm currently working in the long-term care side of healthcare, and we have a rehab unit, and we get a lot of hospital admissions from the rehab unit, and we work really hard to not have to send people back to the hospital, but sometimes it happens. Hospitals like to get people out as quickly as possible, especially out of when they're having prospective payment. You know, Mrs. Smith's looking fine, it's great. She can't go home. Well, maybe we'll send her over to the nursing home for a while, which is fine, that's great. We love having her. But let's say she has an infection or something that maybe went a little undetected, or she comes over with something complicated after she's stabilized in the hospital. We get her, but then if she gets really sick and we have to send her back, then the hospital gets penalized for it. And then we in turn get penalized for it, and then the hospital's not happy with us. So the long and the short of it is readmissions are bad, so we should just try to keep people as healthy as possible. Let's see, psychiatric DRGs. Psych DRGs are based on a per diem, not a case-by-case basis, because it's based on the reimbursement that psychiatric hospitals require to keep that person in-house. There is a stop-loss provision to prevent against significant losses, which means they cap the benefit that they pay out. OPPS, or Outpatient Prospective Payment System, think of it as DRGs for outpatient. But it's a service provided by a hospital outpatient department and or non-hospital ambulatory surgery centers. There's 300 procedural groups. So you have a diagnosis, but then there's 300 procedural groups that tie to those diagnoses. And there's new technology codes, APC. So if you get a really cool gizmo or gadget that's warranted for reimbursement, you can get an APC code assigned to it. And outpatient prospective payment, like I was talking about for knee surgeries and stuff like that, oftentimes come in a bundled format. So that includes everything, anesthesia, the surgery, everything. Now, that said, for outpatient prospective payment, that physician services, so the doc fee, can be paid separately. Case mix methods, what it does is it tries to aggregate the severity mix. So a comprehensive assessment is done, and through that assessment, particular care or a case is categorized and given an acuity level, and then that's put into an acuity group, and a case mix group or CMG is used to reimburse the inpatient facility, usually rehab facility, for that service based on that case mix. We run an outpatient rehab facility, and people come, so they come when they are getting knees replaced or they have surgery or something like that, and we're constantly doing analysis to figure out the acuity of our patients, and then report that in, and then Medicare will adjust up or down our reimbursement, our daily reimbursement, based on the severity of the patients that we'd seen for that period. So if we do a bad job of coding and our patients are actually sicker than our data says, well, we'll get paid less, but we still have to provide the high level of care. So it's a performance issue for the billing and coding and MDS people at facilities like ours. So now I'm on slide, looks like slide 69, home health resource groups. Home health care is paid prospectively as well. It's fixed and it's predetermined for a 60-day period, regardless of what services are delivered. So a big assessment is done, and a reimbursement, a daily reimbursement rate is set and agreed to with the home health agency for a 60-day period. Now you can, if something big happens, you can, appeal and try to get another, but in general, that's what you're stuck with for the 60 days. They're bundled under one payment on a per patient basis. DME and drugs are not included in those, and that's a really big deal. Durable medical equipment, that's what DME is. So walkers, handrails, wheelchairs, stuff like that. That's what's considered durable medical equipment. An Oasis is used. The Outcome and Assessment Information Set, or OASIS. That's that big assessment that I just mentioned. It's used to assign patients to one of 153 categories, which then helps drive home health reimbursement. How do funds actually get into the hands of the providers? Well, through claims. Physicians, hospitals, home health agencies, rehab groups submit claims to the payer. I mean, let's use Medicare as the example. And then services are provided, a claim is created, that claim goes to the insurance company or the payer. The payer processes it, and funds are released back to the provider organization. Third-party administrators are organizations that, let's say someone's self-insured. So you have so many employees that you can justify being your own group. Well, you be your own group if for insurance purposes, but maybe you don't know how to run the insurance side of things, then you contract with their third-party payer like United or Blue Cross, and they become your third-party administrator, and they process and help process and pay claims or get claims paid for you. And they also monitor utilization to help make sure that you're reporting what you're supposed to and things like that. Medicare and Medicaid can use fiscal intermediaries and carriers, so someone that just cuts checks and whatnot. So now I'm on slide 71, and just to give you an idea, this data is 8 years old, but it's still kind of mind-blowing. In 2010, $2.6 trillion were spent, and that comes out to be $8,400 per person in the United States. I don't know about you, but I didn't use up $8,000 worth of care last year. Someone did, so that's the average. It takes up about 18% of the gross domestic product. Remember, the gross domestic product is a measure of the total economic output of the country. So you have healthcare and defense and education, things like that. It takes up 18%. That's a lot. In 2020, so 2 years from now, we expect to be spending almost $4.5 trillion on healthcare. That's a lot. $4.5 trillion. And it's going to be over 19% of the gross domestic product. So what do? GDP for national health, what goes into national health expenditures for GDP? All services, products, and supplies. There's a table in Chapter 6, table number 4, that tells you everything that goes into the GDP. But it's all that stuff you see on 6.4 or 6-4, but also all your public health services, all healthcare research, any administrative costs, all the complexities of paperwork and stuff like that get lumped into healthcare expenditures, which is part of the reason why our country is so considered to be so expensive. Also includes investments in infrastructure and whatnot. And figure 6.6 or 6-6 shows the ongoing proportional shift from private spending to public spending. There's a shift to the public dollar. And a lot of that, quite honestly, can be political. Some parties, some groups, some legislators see the value of having the government take control of it. Is healthcare a right or a privilege? If it's a right, maybe a constitutional right, then it's the government's business to take more control of it. If it's a privilege, because it's private and all that kind of stuff, maybe not. So the Affordable Care Act was meant to significantly shift the ratio toward public financing in 2014. The administration that was in charge with the Affordable Care Act really saw the government as key to being a good steward to the healthcare resource, and that was a tool that they tried to use. In 2017, there was an estimated 30 million uninsured people, and the 10-year federal cost up until that point, or between 2014 and 2013, are expected to be about 1.3 billion. And that's just for the federal government. That doesn't include anything that the state did. It also takes out any costs by newly insured, And then, now this is almost in hindsight, this is on slide 74, that it turns out, this has actually been realized, that the Affordable Care Act actually resulted in higher costs to employers and employees in the form of increased premiums and things like that. So that's part of the big hullabaloo right now around, that continues around the Affordable Care Act. I suggest you take a look at slide 75. I mean, these are just good points about risk selection. High risk individuals have a greater incentive than low risk individuals to use health insurance. I think we talked about that. If you're sick, and you know you're sick, if one is sick and one knows they're sick and they can't afford, or they can't afford health care out of their own pocket, there's an incentive for them to want a health benefit like the Affordable Care Act. So, and once they have a health benefit, they're going to use it, which will drive cost up. Might increase their productivity. I mean, this is where, you know, money discussions get really, really interesting. Is that because, well, if someone's healthy and they can go back to work, then they're paying more taxes, then it was worth the investment. Or you just, other people say, well, you know, increased expense is just no good no matter what. So it depends. I guess there's no, I don't know if there's a right or a wrong answer on it, but it sure is up for a lot of debate. Younger workforces generally don't like insurance. They feel it's a waste of their money. They'd rather use it for rent or a car or a trip or something like that, because they're young and healthy and they don't use their health benefit. Let's see, an unintended consequence of the ACA could be that individuals purchasing insurance only after they have healthcare needs and subsequently canceling coverage once they don't need it. I haven't seen anything updated on that. That came out in about 2013. Thought was using exchanges. You know something's coming up and you're not dying, but you know something's coming up. You go, you get health insurance, buy it, use it, and then you disenroll until you need it again, and then you enroll. But that takes out the benefit of shoveling premium dollars into that shared pool for other people to use in between times when you use it. They're seeing that, they're predicting that as an unintentional or an unforeseen consequence to the Affordable Care Act. There's still cost shifting, which higher premiums are a form of cost shifting, that insurance companies didn't bear the brunt of the increased expense because of the Affordable Care Act. What they did is they just increased the premium cost to we, the employees, and the employers. And that was not necessarily seen, but it's definitely considered an issue that the employers don't like. There's concern about fraud and abuse. That's the very last slide. Fraudulent billing may amount to 3 to 10% of total healthcare spending. There's some sneaky, fraud is illegal and it's wrong. But there are a lot of people out there, looking to scrape 3 to 10% off the top for themselves through fraudulent billing. That's billing for things that never happened, upcoding when it's inappropriate, things like that. And remember, we're talking about $4.5 trillion. 3 to 10% of $4.5 trillion is a lot. So that's why it's considered significant. If someone is suspected of fraud, Medicare suspects someone of fraud, what they'll do is they will suspend payments, so they won't let you see any more Medicaid patients. And then you also may not be, if they find that you're guilty, you may never be able to provide service to a Medicare or Medicaid person again. So that's Chapter 6. Hope that was helpful, and we'll see you for Chapter 7. Thanks.